Welcome to T's Voices, telling the stories of the people in our NHS community.
Hello and welcome to the podcast. I am honoured and privileged to have Kirsty and Emma, our AHP consultants, with us today on this podcast. So how did it all start?
Okay, so my name's Emma Thompson. I'm a consultant radiographer specialising in breast cancer treatment. And my role came about because there is a national shortage of clinical oncologists. So they looked at their job roles and they thought, okay, so which part of these job roles can we roll out to an AHP? So a lot of breast cancer treatment is very protocolised. So they sort of thought, well, okay, we can get a radiographer doing this. So radiographers look after patients during treatment, they do the treatment planning, talk to people about consent issues, side effects. So really, we're really well placed to step into that position. So right from the start, I was quite lucky because I had a clear scope of practice and the consultants knew what they wanted for me. So I worked as a radiographer for a long time. I'd also worked in clinical trials. I'd worked for Macmillan. So I'd been in various different roles. So this role for me was really exciting to get my teeth stuck into. And I had loads of support. I managed to identify training needs. I'd already got a master's degree, so I didn't actually go down that route. I added on additional courses that I needed. Created a portfolio and was deemed to be competent 2020. That's me.
So for me, I mean, the start of my journey was I started in the trust in 1999, working as an assistant in the back of the hospital in like a shed I don't know really what it was, Ward 15. So I worked as an OT assistant, did that for a couple of years, went to night school on an access course, then ended up going to university to do my OT degree. Did that for 3 years, came back, got a job as a band 5 on rotation, but still knew that I wanted to be back in stroke. That's where my love was. So ended up getting a job as a band 6 in stroke. Then I got a job as a band 7. I did my masters in service improvement. I've done my advanced clinical practice masters too. Then very much like Emma, there was a national shortage of rehabilitation stroke consultants. At the time, we had 3 permanent consultants retire, so they couldn't get anybody. So it was a case of looking at what could we do in that place. And in the national guidelines, they did stipulate that it could be for rehabilitation, there could be an AHP consultant in that post. I was really lucky to have the support of James Dunbar and Michelle Watson, who really supported the post. Got into post, had to do the competencies, went through everything and ended up in the post, yeah.
So I'm thinking there's probably a lot of people that are not sure what an AHP consultant is, and how many of you guys are there out there?
From a stroke point of view, in the country, there'll be about 8 now. When I got in, there was only, I was the 6th one in stroke, so they're far and few between.
So you're a very niche kind of thing, isn't it? So is this fairly new, is it, the consultant role for allied health professionals?
Yeah, absolutely. I think it's something that's been growing over the last few years. So I think in breast cancer radiotherapy, there's probably about 20 of us now. And it's quite nice because we have a network to support each other through that as well. So.
But from a South Tees point of view, Kirsty and Emma are the only 2 AHPs at consultant level currently.
Yeah.
And that's something that I think we all need to look at, as in how do we develop that? What do you actually do? What's your caseloads like?
Yeah. So for me, I'm the named consultant over 16 beds at Redcar. I have 17 beds over at the Friarbridge Hospital, stroke ESD in Tees and Hammerbridge, so that varies between, I would say, it can be anything from 30 to 45 patients on that caseload at one time. I do all the follow-up clinics for everybody that lives in Hambleton and Richmond that have had strokes. So I do them face-to-face, 6 to 8 weeks follow-up. Yeah, so it is busy. And on top of that, I'm doing my PhD as well. So, yeah, I'm juggling the plates.
This stuff's not for the light-hearted then, is it?
No,
You've got to go into this eyes wide open.
100%, and I'm sure Emma will agree, you are accountable. It's not a case of me saying, oh, there's been a mistake. You're accountable for them patients, for the care they receive, from all the professions involved. You overarch that. You're the person that is held accountable, yeah.
So what about you, Emma? What's your caseloads look like?
So I see about 350 patients a year. Do their follow-up as well, again at 6 to 8 weeks. I manage their endocrine therapy if they've got problems with that. I also act as the lead on breast radiotherapy. So we are constantly trying to evolve our radiotherapy techniques and make sure it's, the quality assurance is absolutely top-notch. And we participate in a number of clinical trials as well. So patient workload, and just like yourself, Kirsty, I am that patient's named consultant, so you're working totally autonomously, although I do get support of the consultants if I have any queries, or we all email around each other actually sometimes for more complex cases. But I also had leadership roles on, so I'm a leader on breast radiotherapy, and I get very involved in clinical trials as well. I'm the cancer research lead in the department. It's a busy old time, and we all job plan our time, but sometimes it's about juggling, isn't it?
Definitely. And I will say, since I've settled in the role, Dr. Ali Husseini and Dr. George Thomas from Tees, they're supportive with stroke issues, and Dr. Alan Malai from North Tees, and it is being recognised now, and they are supporting. It's just, I think it's difficult for us as we are alone, if you like, and it was nice to speak to Emma finally to say, what type of issues I'd come up against, and a few barriers, and you almost feel like I felt as if I was having to prove what I was doing. But, I'm over 12 months down now. And fingers crossed and touch wood, the feedback's been good from patients, and I've really enjoyed it. It's challenging, but I do think it's a place for AHPs to be, definitely.
So I'm curious why we don't have more consultant AHPs. What's the barriers, and why? What do we need to make sure that there's space for this type of work?
From a rehabilitation point of view, I suppose it's very much that person working at that level clinically, having the leadership skills, having the service improvement skills, having the education skills behind them. It's not just, some people will say to me, oh, well, I'm a clinical expert in that field. I'm not just that. There's a lot more that comes with it. There's a package, and I think it's linking more in with the medics. I think from a stroke point of view, I'm very lucky. The national lead is very, very pro AHP consultants, and with this job, with mine being has gone as well as it has, she actually contacted me and got my job description, and I have regular talks with her, and they've now got a consultant AHP being put in post in the Wirral due to that. It's definitely moving forward, and I would imagine it's the same for you, Emma.
Yeah, it's about identifying that service need, isn't it? And business planning with your department, looking at what staff mix you want in that department. So we're seeing a lot more AHPs acting as advanced clinical practitioners, and obviously at some point they would like to make that jump to consultant. Well, not obviously.
No.
But some of them might want to do that. So I think we need to support them, but also get that mix of the medical groups as well. So I think sometimes, the person best suited to a job might be a medical clinician. Mm-hmm. Other times it could well be an AHP.
Yeah.
So those sort of radiotherapy issues that are sort of bread and butter to me, that's where my skills really come in.
Yeah. And I think for me, it's like you look at rehabilitation. For somebody to be well enough to participate in rehabilitation, they need to be medically optimised. So the beginning part of the pathway for me for stroke is the acute ward. That's key. I don't betray to be a consultant in acute. I'm a rehabilitation stroke consultant, and there are different needs that are needed within them roles and different expertise. And it's how you look at the person holistically. Yes, they need to be medically optimised, but after that, they've got a long journey in rehabilitation and recovery, and that's where the allied health professions definitely come in.
Yeah, I think there's a job that we all need to do is make us a bit more visible, so people understand, so that there can be people in whatever room that they're in making those decisions. Could be, do you know what, we've got a gap here. Why don't we look at this? Why don't we look at AHPs? Why don't we look at this service? And I think getting that exposure so people, whoever's in the room, can go, could be a nurse, could be an AHP, could be a consultant. And I think it's probably our job to really promote us, and hopefully this will help doing that. So as we're coming towards the end of the podcast, for the AHPs out there that are listening to you thinking, oh my God, you're my inspiration, like me and Jen are very much feeling, what would be your take-home message, your bit of inspiration to say, if someone's wanting to go for it?
Always believe in your dreams and believe in yourself.
Absolutely. And if you see opportunities, take them. Don't be scared.
Yeah, push yourself out of your comfort zone.
Yeah.
I have absolutely thoroughly enjoyed spending this time with you. I've learnt so much, and thank you so much for coming and spending some time with us. Look after yourselves.
And each other.
Yeah.
Thank you.
Thank you.
Thank you for joining us. Till next time, you've been listening to T's Voices.